Thank you all. I'm very happy to see you here again this week for our Whom You Love series. I know it's a gloomy day out there, but I was a little bit worried that the warm temperatures would have everyone at the beach instead of here, and so I'm glad to see that you came here. And I know it's been a long semester, but I think you're really in for a treat. I'm extremely excited to have the opportunity to have Alice Dreger talk to us today. Alice, if I gave you her academic history in the usual way, you know, she got a bachelor's degree at SUNY, and then she got a master's and Ph.D. At Indiana University in I better get it right, the history and philosophy of science. I started to say the other way around. But to really know why we're so lucky to have Alice here today, you need to see the things she's been publishing. So first she's written two wonderful books, one about hermaphrodites, which is really a wonderful look at the history of how the medical profession has regarded people with what we would now call disorders of sexual development, among other things. And then a second book she wrote about conjoined twins, One of Us. I guarantee if you read that book, it will change forever the way you think about conjoined twins, especially when you see things in the media about hospitals rushing in to do emergency surgery to separate twins. If you read her book, I'm betting you'll read those stories a little differently from now on. She is also incredibly prolific and very visible in the media. She has been on Oprah. She has met Oprah, and I just found out that just last week she was getting bashed by Rush Limbaugh for her Ph.D. dissertation. How many of us can cite something as wonderful as that having happened to us? Definitely a badge of honor. She I also want to get this right, she is currently a professor of clinical medical humanities and bioethics at Northwestern University, but I'm happy to say that she's also an East Lansing resident, so we still get to take advantage of her community activism skills that many of you may know about. So I want to remind you that we are still going to try to reschedule Michael Bailey. I meant to tell you this earlier, for a later date. Don't know when yet. It'll be after the new year, but I'll post it on the website, whomyoulove.com, and we'll put it on the Facebook page, Whom You Love. And without further ado, I promise you, you're going to have an interesting, thought-provoking lecture from Alice Dreger. Please welcome her.
Thank you. Thanks, Mark. I have to disclose that Rush Limbaugh was not specifically bashing my dissertation. He was bashing a piece I wrote in The Atlantic about football and head injuries and sexual dysfunction. But he needed to apparently fill airtime, so he pulled up my CV and he started reading from my CV, which was really, really funny, because I never thought when I was doing my dissertation that someday Rush Limbaugh would read the title of my dissertation on his show, which is a very boring, PhD history title, so it was really funny. And actually, the way I found out about it was a little horrifying, because my brother called me and told me that Rush Limbaugh was bashing me, and I was really worried about my brother. But he explained to me that he was out of coffee and he needed something to get him going, so he had turned on Limbaugh and was shocked to hear him talking about my stuff. So my partner is a physician, and when my relatives call and ask for medical advice, he always starts by saying, this advice is worth what you're paying for it. So I just want to disclose to you I'm not being paid for this talk, because I actually sleep with an administrator who runs a department that actually fed money into this system. So unless I wanted to get into a grand East Lansing sex and money scandal, I had to decline Mark's kind offer to pay me like everybody else. Sex and money scandals are good for selling books, but probably once they found out I was married to the guy, it would not have sold the book. So, although I do, and you'll have to read my next book to learn why this happened, I am probably the first person in history charged with an ethical violation for having confessed to having had sex with my husband. He was the second person in history because he joked about it and then got charged by the same person. But that's another story altogether. So here's what we're going to do today. I'm going to do a 5-part talk and just move through it step by step so you can follow it. First, I'm going to talk a little bit about my background, just so you know where I'm coming from, because a lot of times people describe me as a scientist. Although I'm a social scientist in that I do history, I'm not a scientist of the type you've been seeing in this series, so my approach is different. And I also want to tell you a little bit about that background, just to give you an idea of why I'm concerned about the study of sexual orientation, and why I think it's really important and useful and hopeful, but why in terms of the applications, we do have reasons to be concerned. Then give you an overview of a few key themes from this whole series. I've been coming to this series since I live here. And that will allow me to just hit the points that are important for my talk. There's lots of really interesting themes in this series, but I'm going to hit the ones that matter for what I'm talking to you about. Then I'm going to give you a quick overview of history of attempts to treat homosexuality medically, to try to take people who are gay and lesbian and cure them of it. And that's going to be really fast. It's going to be like 200 years in 5 minutes. But the reason I'm doing that is to encourage you to understand that there has been a long and painful history of people who are gay and lesbian being, quote unquote, treated by medical doctors in an attempt to cure them. So whereas a lot of people know the worst parts of gay and lesbian history, things like the Holocaust, where gay and lesbian people were specifically sent to the gas chambers, they don't know the medicalized attempts that also contributed to a sort of generalized sense that being gay or lesbian is unacceptable culturally and needs to be stamped out. And then I'm going to give you a case study where we actually see something really going on, where there have been attempts to see whether or not you could prevent an individual from turning out to be homosexual by treating them as a fetus in the womb. And this is a bit of work that I spent the last 2.5 years working on, so this is the focus of my own recent work. And then finally, I'm going to talk with you about parenting. What's wrong with trying to engineer a child's sexual orientation to make him or her straight or gay? And close with that, talking about parenting specifically. Okay, so a little bit about my background. Mark mentioned that I did my degree at Indiana, and I did my degree in history and philosophy of science. So by training, I'm really a historian of science. And when I was doing graduate school, my dissertation director, Fred Churchill, knew that I was interested in gender and science. So he said, why don't you look at the history of hermaphroditism, because that hasn't been studied. And I thought, well, okay, cool. I'll look at Darwin's barnacles, because they were hermaphroditic, and Darwin had to struggle with what that meant. I'll look at the history of embryology. But Fred kept saying, look at medicine, look at medicine. And I was wondering why it doesn't happen in humans past the embryological stage. So when I was 25, I didn't know that, in fact, humans can be born with various kinds of sex anomalies that leave them with a kind of sex that's in between male or female. And it turns out there's lots of different types. There's at least 30 different types of ways that this can happen. Some of them involve ambiguity, where you have external ambiguity, and I'll show you some sketches of what that looks like. So genitals that are halfway between the male and the female. But in some cases, you have folks who look very male on the outside and behave male typical, but have female parts on the inside, or vice versa. So there's lots of different ways to get this in humans. And so the first book I ended up publishing was a book based on my dissertation, and that was a book called Hermaphrodites and the Medical Invention of Sex. And it looked at the late 1800s and the early 1900s in France and in Britain to see how doctors struggled with this issue. Well, as I started publishing this work, people who had been born with these conditions started to contact me and to ask me to help them change the current day medical system. So here's just a picture of some of the folks from that period of time. This is 10 folks with various kinds of intersex conditions. The person in the center there was known publicly as Cheryl Chase. Her real name is Beau Laurent. And she was the founder of the Intersex Society of North America. And she introduced me to pretty much all these folks and lots more like them, and wanted me to try to help change the current day medical system. And my reaction was, I do dead people. I don't do living people. Like, I'm the wrong person. But she said something very sensible. She said, well, you consider yourself a feminist. Why don't you just look at what's going on today? And that was very easy for me, because the person I was living with was my future husband, and he was in medical school. So one day on lunch break, I just wandered from my side of the living room, which had all the old books, to his side of the living room that we had paid a lot of money for. And I opened one of his textbooks, and this was a book we had paid a lot of money for. It was like a $180 book even back in the mid-1990s. And I opened to the section on clitoromegaly, which is when a girl is born with a large clitoris. And it actually said in the textbook that if a girl was born with a big clitoris, she might turn out to be a lesbian, so you had to shorten her clitoris surgically in infancy. And I was like, what? And then I opened to the section on hypospadias. Hypospadias is when the urinary opening isn't on the end of the penis where it commonly is, but it's on the underside of the penis, or sometimes down lower. And I'm not making this up. His book actually said that if a boy could not write his name in the snow next to other little boys, he would turn out gay. So you had to do a surgery to move his urethral opening. And when my partner came home, I was like, you gotta look at this stuff. This is wacky. This is crazier than the Victorian stuff I'm studying. And I was also fascinated because, I'd grown up a girl. I said to him, did you write your name in the snow next to other little boys? And he said to me, no, do you think I'm gay? And we were like, what the heck is going on with medicine? So I thought I would help the folks with the Intersex Society for 6 months, and we would go to the doctors, and we would say, this is crazy, this is nuts, this is a 1950s system, and we're in the 1990s, and like being gay and lesbian is fine, messing with people's sexuality for social reasons is a bad idea, and they would say, oh gosh, yes, we were so silly, we meant to change this, thank you, we forgot, and they would change it. And that was stupid of me. It took 10 or 15 years to actually get them to change a lot of it. But a lot of it has changed. The folks in the intersex rights movement have been extremely successful. So after that, I ended up publishing a book that was called Intersex in the Age of Ethics. And that was a book that brought together the stories of folks like this that were missing from the medical literature, that talked about people who had slipped through the system, who were doing fine with ambiguous genitals, people who had been medically treated, who had been very damaged by being lied to, because many people have been lied to in the system, who had been surgically changed in ways that harmed them, some of whom who had been sex changed in childhood, who then reverted back and regretted not having the parts that they were born with. So we captured that as well as a bunch of academic critiques of what had happened. And so I also became a member of the Intersex Society's board. So we developed, actually this was developed, it's a great tool. You can see that you can already see it's called a philometer and the big one's called surgeon. But this was a tool developed by Kira Tria, who was an intersex activist based on an idea from Suzanne Kessler as social psychologist. And it basically did capture what was going on within the medical system when the intersex rights movement started. And that was that if a girl was born with a clitoris shorter than 0.9 centimeters, which is quite small, 3/8 of an inch, then she counted as a standard girl and nothing happened. But if she had a clitoris larger than that, the textbooks all said, and the medical professionals all said, it's too large, it's dangerous socially, and you have to reduce her clitoral size for social reasons. They called this a social emergency. That's what the textbooks called it at the time. If a genetic male was born with a phallus length larger than 2.5 centimeters, so that's an inch stretched at birth, that counted as a standard male, so that's why down here it says just squeaks by, then phew, okay, then Texan, then wow, surgeon. Because it was a joke tool, but it did explain to people what was going on. If a boy was born like that, then he was left male, but if it was shorter than that, according to the textbooks, he would not grow up to be an adequate male, and so you should sex change him. So they did sex change baby boys simply based on phallus length. This was really nutty, as you can imagine. So the movement was very angry and upset and effective in the long run. So that's kind of where I'm coming out of. So just again, my background is really in terms of patient advocacy and medical history, and I'm very much a science geek. I love science, and I've been really interested in all the science about sexual orientation, but as I look at it, I of course think historically and think, what could come out of the kinds of work that we're doing today? So that's my background. Now we're going to go to an overview of a few key themes from the series that I just want to highlight for the sake of my talk. One is that cases of atypical sex, like the kinds of stuff I just described, suggest that gender has an inborn component. And just 3 quick examples. So you've heard some of the speakers talk about congenital adrenal hyperplasia. I'll talk more about this later in the talk, but this is a condition where the adrenal glands in the back of our body are in very high gear congenitally. So it's a genetic condition where a person has the adrenal glands pumping too hard, essentially. And this results in a high level of masculine hormones being in the blood. Now, this can be dangerous for metabolic reasons, so it's a disease that gets treated, but it has a side effect that in a genetic female, it can lead to the genitals being masculinized in the womb. So that means the genitals could be ambiguous or could even look quite male-like. In such cases, these outcome studies have documented pretty clearly that the girls with higher levels of masculinizing hormones in utero have a higher rate of being tomboys, of being interested in male-typical activities as boys, and have a higher interest in male-typical occupations. So that's one of the cases that suggests to us that the levels of prenatal hormones can have an effect on how gender identity develops. Androgen insensitivity syndrome is another good example, and androgen insensitivity syndrome is a condition where a genetic female has XY chromosomes, genetic male has XY chromosomes, so genetic male, testes develop in the womb, and the testes start operating normally. But because the fetus is androgen insensitive, they don't have the receptors to respond to those hormones, the body changes along the much more typical female pattern. So when they're born, they look female typical, and typically nobody thinks anything's up. Everybody thinks, oh, it's a baby girl. And it's only when she reaches puberty and she doesn't menstruate that somebody does a vaginal exam and realizes that although the child has a vulva and a vagina, there's no cervix, there's no uterus, and in fact, she in fact has testes. In such cases, because there's no androgen receptors, such women actually are less androgenized than typical women. So typical women make androgens and we respond to them. Our adrenal glands are making androgens and we're responding to them. In the woman with AIS, she's got adrenal glands and she's got testes and they're making androgens, but there's no response to it. So technically speaking, her brain and her body is getting less androgen effect than the typical female, okay? In such cases, these girls tend to be quite female typical. They tend to be interested in traditionally female typical toys, in play behaviors and interests. Most of them end up straight. They have a rate of lesbianism that's certainly no higher than the general population. So they seem to be quite female typical. Again, this suggests to us that the effect of androgens has some level of influence on gendered behaviors in childhood and also later in adulthood. And then there's the issue of sex reassignment of males, and you may have heard of quite a famous case from the book As Nature Made Him by John Colapinto. This was the case of David Reimer. David Reimer was born a typical male with a twin brother who's also typical male. But at the age of 8 months, they had a minor issue with their penises. They had a condition called phimosis. And the doctor went to fix this by doing castration. And when he went to do the castration on David, he accidentally burned off his penis. He used a bad technique and caused a traumatic accident. So the consequence was you had a boy without a penis. Well, at the time, the standard line was a boy without a penis can't grow up to be a man, so you make him into a girl. So that's what happened to David Reimer, as it happened to a lot of intersex folks. And he ended up in the same system as all those folks. He ended up at the age of 14 having his father finally tell him the truth of what had happened. He'd been raised a girl, never behaved in a girlish fashion, really had been quite male typical, even though people had been sort of pushing her, I should say, to be very female typical. It really hadn't worked. And so this was the really famous case that caused a lot of scientists to say, well, maybe gender has a strong nature component, a strong inborn component. There's lots of other cases where folks have been sex assigned as males. Some of them do end up as women, but a much higher percentage of them end up reverting to become males than you would see in the general population. So this suggests to us that gender has an inborn component to it. It doesn't mean it's all inborn, but it has a component. Secondly, related to that, cases of atypical sex also suggest that sexual orientation has an inborn component. So who you're attracted to, again, seems to be influenced in part by, it looks like, prenatal androgen levels. That's probably not the only thing influencing it by any means, but it seems to have some level of that going on. So if we look at the large populations of people who are born with atypical sex, and I'll just give you pictures of some of the adults who've donated their pictures for us to talk about them as real human beings. This is a group of women from the AIS DSD support group, a bunch of guys with a woman supporter from the Hypospadias support group. These are just folks you would meet on the street and never know that they had been born with one of these conditions that causes their sex to develop differently. If you look at these populations and look at them in the aggregate and you sort out what the androgen levels were prenatally in terms of each different group, it again looks like sexual orientation has an inborn component. So it looks like there are, it is the case that if you have low levels of androgen receptivity, then you're going to end up more likely to be attracted to males. Higher levels, you're more likely to be attracted to females. This again is true in the case of CAH, where you have that higher rate of lesbianism and bisexuality among females who have CAH. And then thirdly, childhood gendered behaviors seem to be correlated with adult sexual orientation. So that they're not a perfect indicator of what you're going to turn out to be in terms of gay, straight, or bi. But if you look at childhood gendered behaviors, interests, these kinds of things, they do correlate to a certain degree. It's not random. They do correlate. So one of the things we found, for example, is that children who get diagnosed as having gender dysphoria have a much higher rate of turning out to be gay men or lesbian women than the general population. Some of them also end up to be transgender individuals, but most of them turn out to be gay men and lesbians. If you do recalled childhood memories among gay men and lesbians, they do recall more gender cross behavior, in other words, more typical of the other gender as children, on average. Again, not everybody, but on average there seems to be some sort of correlation. So this would suggest to us that sexual orientation has an inborn component to it. And this would be true for straight people as well as gay people. So in the series we've tended to examine what's going on with gay people, but we actually don't know where straight people come from either. And the same answers to the questions for where do gay people come from help us think about where do straight people come from. I actually published a piece in The Atlantic called Are Straight People Born That Way? Because I wanted to ask the question that everybody asked about gay people. And the answer is, we don't really know. What we know is that the majority of people are straight, and evolution would certainly favor that. But we don't actually know for any given individual why a man would turn out to be attracted to women or why a woman would turn out to be attracted to men. And we tend not to answer that question because we problematize gay and lesbian people, and yet I think it's useful to also problematize straight people. In fact, what I wanted to call that article, and it's in there in the text, but it's not in the headline, is, Are Straight People Born That Way, and Should They Be Allowed to Marry? And my conclusion at the end was, yes, we should let them marry because these poor sops have to end up married to somebody with whom they have so much less in common than a gay man has with a gay man or a straight woman has with a straight woman. The least we could do for them is to let them go ahead and marry who they're in love with, right? It's the least we could do for these poor souls. So if you went to Paul Vasey's talk where he talked about the folks in Samoa, you saw him talking about this. And this is true cross-culturally, that if you look cross-culturally in places like Samoa where boys are gender atypical, they turn out to grow up to be what we would call gay, that is, they're attracted to other males. So it's really interesting that this is not just an effect of Western culture, it seems to carry into other cultures as well. So again, it suggests to us that there is a correlation between childhood gendered behaviors and sexual orientation, which would lead us to believe that there is some biological component to gendered behaviors and also sexual orientation. Now, how one's biology plays out in terms of lived experience depends on one's culture. So I've got a piece actually coming out in The Atlantic tomorrow about 2 cultures that a group of anthropologists studied that seem to have no homosexuality and, much weirder, no masturbation. So why would that happen? Well, I try to unpack there with those anthropologists this question, but what it looks like is that in some places you can have the same biological substrate, but given a different cultural situation, it's going to look very different. So those places happen to be 2 cultures where having sex is understood as being primarily about making babies, and so heterosexual couples have a lot of sex at night, and they see it as the work of the night because they need to have a lot of children. They're in an area with a very high infant mortality rate. So if you want to have kids, you unfortunately have to have a lot of kids because a lot of them are going to die. So it looks like in such a place, it looks very different. And one of the things they talked with me about, which was really interesting, was that, you know, whereas in westernized culture, you have a whole system of electricity, where you have heat, you don't have to tend to fire, where you've got to go to work in the morning, we don't see staying up all night as having sex as really fun, except when you're first dating, right? We would see that as a dreadful way to think about sexual relations. But in a place where you've got a situation where you have to tend the baby, tend the fire, and also where you don't have to get up to go to work in the morning, you have to get up to take care of stuff, but you don't have to go to a job that expects you to be there at 8 o'clock, sex is treated very differently. So for straight people, as well as for gay people, how that biology plays out depends a lot on the cultural situation. So in Samoa, what you see is somebody who probably in our culture would turn out to be a gay man, turns out to be a woman in terms of the way she lives. And, you know, I even asked Paul, who's a good friend of mine, so is it weird for you to think that if you had been born and grown up in Samoa, because Paul's gay, if you'd been born and grown up in Samoa, you'd be a woman? And he said, no, because I'm an anthropologist and I get that that's how my life would have been. I would have had the same body, because the folks in Samoa don't change their body, they keep the same body, but they live as women. The Fa'afafine are males living as women. And Paul was very cool about that and says, yeah, that's the way it works out in different cultures. So finally, I would add that in the audience, what I heard from different talks is some people worry that scientific study of sexual orientation might lead to anti-LGBT applications. And I think that's a perfectly reasonable worry that folks have. It's not a reason to stop the science, but it is a reason to think carefully about, as we do this science, how is it going to play out in terms of applications? So I'm going to talk next about that. Since we've talked about the overview, we're going to do the history of attempts to treat homosexuality, just to give you a background in terms of what's gone on in Western medicine. And some of them, I have to warn you, are funny, and some of them are horrifying. So just to start, with 20th century medical treatments of for homosexuality, and I take this from a compilation that was put together by Tim Murphy. There's just a 3-page article that goes through all these different things. If you'd like it, it's especially good for teaching purposes. I'm happy to send it to you. Tim really did a great job putting these together. The first one is actually from the late 19th century, but it recommended extensive bicycling as a way to deal with homosexual urges. And the notion was that homosexual urges came from having too much sexual energy, and so the way you could deal with it was simply by doing excessive exercise, and excessive bicycling was recommended. I think this is funny because of the studies that have shown nowadays that too much bicycling can make you impotent. So in retrospect, I'm tempted to read that onto this and to say, well, at the very least, probably too much bicycling would make you impotent, but extensive bicycling was recommended. Castration in 1929 was recommended as a solution to homosexuality. It certainly does reduce the sex drive. I will tell you, however, it does not seem to have any effect on sexual orientation. So we've had actually studies of men who've been castrated for various reasons through time. And while it does reduce drive, it does not seem to improve outcomes in terms of what's gone for here. In addition to that, in the 1940s, various folks in Europe tried gonadal transplants. So they tried implanting testes into gay men to see whether or not giving them testes from another man would somehow make them straight. They were used from cadavers. Psychoanalysis started in the 1950s, and this focused a lot on the idea of trying to recall bad childhood issues and try to correct for these things. And these, of course, quite extensive based on Freud's ideas of how male and female sexuality develops. In the 1950s, these clitorectomies on girls started, and I've already told you a little bit about this, and also the sex change on boys, as an attempt to prevent a situation where you didn't have a real man or a real woman, meaning you had somebody who grew up to be homosexual relative to the gender they were assigned, and that's where that phallometer came in. It continued. Aversion therapies were used in the 1960s. Some of these were actually quite gruesome. So some of the things that would happen, for example, is that gay pornography would be shown to gay men, and then there would be some sort of aversion given associated with that. So sometimes a drug that would then make you vomit, or you would be surrounded by jars of your own urine and asked to watch pornography of a particular type with the idea that this would make you averse to that. They were quite gruesome a lot of the times. Electroshock therapy was actually used to try to cure gay and lesbian people. And I should note, as Murphy does in the article where he summarized all of this, most gay and lesbian people did not go to doctors to try to be cured. But a few of them did, because a few of them found that their situation was so intolerable in terms of their social situation that they wanted to be cured. But the great majority of gay and lesbian people through time did not seek out physicians. Some people were also forced to go into medical treatments. So what happened was that at the time that engaging in homosexual acts was illegal, the police could actually, the court system could force you to be subject to some sexual intervention therapies, as they were called. So for example, you may know Alan Turing as the father of the modern computer. Alan Turing, when he was found to be engaging in homosexual behavior, was actually forced to take estrogen. And this is a very traumatic thing for a man to do if he doesn't want to be on estrogen therapy, and Turing ended up killing himself within a couple years of this. Forced masturbation was another thing that was done, the idea being that you were supposed to think about women, and if you were a man, and this somehow, if you did this while you were masturbating, that this would cure you of the urge to be with men. Women were recommended the same thing in the opposite direction. Various conversion therapies have been used from the 1970s to today, so some of these are the pray the gay away approach. Other types of conversion therapies have been used to try to get rid of gay and lesbian people. Now, I'll note that some of the people who promote these ideas claim that they work. But I have to say that if they really did work, we would know. Because being gay and lesbian has been hard enough that I think a lot of people would have been forced into a system if people believed it actually did work. Fortunately, by this point, by the 1970s, 1960s, 1970s, the gay and lesbian rights movement came around and finally started fighting back against these therapies. And today we have a new system which is attempts to do prenatal prevention. And I'm going to give you now just that example of the one I've been working on for 2.5 years now. And that's the case study of prenatal dexamethasone for congenital adrenal hyperplasia. So, CAH. I'm just going to give you a picture again of a real human being because I like to put real human being faces on these conditions that sound kind of scary. Janet Green has allowed me to use her photograph for this purpose. Janet Green is an adult woman with congenital adrenal hyperplasia. She was born before the era that this therapy that I'm going to talk about was used, or I should say intervention. Janet was born in the 1950s, and she was born with ambiguous genitalia. She's told her story. Her parents had recommended to them, as everybody did at that point, who came into these medical systems, that she have genital surgery, which she was subject to. Janet, like other people with CAH, has a medical problem. CAH is a medical problem, and you can actually have a sort of adrenal crisis sometimes if something triggers it. So that can be a high fever, or getting into an accident. So Janet actually wears a medical alert bracelet that indicates that she has CAH, and she monitors her adrenal hormones every day. This is something you have to do if you have CAH. And I want to impress upon you that the prenatal intervention I'm going to talk about doesn't do anything for the disease. All it's aimed at is preventing the sex atypicality. Okay, so CAH is a real disease. Janet is currently the interim executive director for Accord Alliance, which is a group that tries to improve the medical care of children who are born with sex anomalies. So what is CAH? CAH is an adrenal disease, so that's the two glands, again, in the back of your body, kind of above your kidneys. And the adrenals are responsible for kind of keeping our bodies in balance. They're part of the endocrine system that keeps the body in balance. CAH is a congenital disease. It's a genetic disease, an autosomal recessive. So if you have 2 carrier parents, 1 out of 4 children will have the disease on average. It's not curable, but it is treatable. It's actually quite treatable today. Today in the United States, all states have newborn screening, mandatory newborn screening for CAH, because CAH in the newborn can actually be fatal if you don't pick it up and the child goes into a crisis for some reason. So it's actually quite enough of a serious condition that it's screened for in all children, or it's supposed to be. Sometimes people forget and they don't do the test. Some forms of CAH can cause sex atypicality in females. It actually causes another kind of sex atypicality in males, but it's not as dramatic as in the females. What happens in the males is you get things like precocious puberty because you've got that very high level of masculine hormones. But in the females, it can cause sex atypicality in the direction of pushing them towards being more like the male. So just a little diagram, don't worry about what all the words mean. If we look at the top here, we see what we all look like in utero at about a couple weeks of life. So our genitals start to develop. And everybody has the same bits at the beginning. Males and females and everybody else has the same bits at the beginning. But what usually happens in most cases is that you either go down the male route or you go down the female route. So down the male route, what would typically happen is you'd have XY chromosomes, you'd develop testes, you have a certain level of androgens. I'm skipping a lot of steps. But basically, the same genitals develop into a male type that in the female, which would be XX, and develop ovaries, because you have lower levels of androgens going around the body or being understood by the body, the same parts develop into the female type. So where in the male you have a penis, in the female you have a clitoris. That's the same organ. Whereas in the male you have a scrotum, in the female you have labium majora. Same organ. So the result of that means that if you have a kind of in-between hormonal mix, what you end up getting is stuff in between. So this shows a typical male, this shows a typical female in a very simplified sketch. And what you can get in somebody with CAH who's XX is something like a big clitoris, sometimes stuff that starts to look more like a scrotum with a penis, something that looks more like a scrotum with a small penis, something that looks like pretty male typical but with hypospadias, so where the urinary opening is down below or on the side. Or you can even, in extreme cases, have somebody who looks quite male typical. CAH varies in females in terms of its effects, and there's different types of CAH. But you can have a girl with CAH who, with no intervention, looks female typical, but you can have girls who are born with stuff that's more dramatic. In some circumstances, you can also have a situation with where a girl with CAH has her urethra and her vagina joined together in development, and that's called a urogenital sinus. And that can be medically significant because you can get infections if you get backwash, and that can cause problems with intercourse later in life. So all other things being equal, life is probably much easier if you're born with standard male genitals, with a male genetic type, with the male type in between, inside, or the standard female. Probably easier. So in theory, the kind of intervention I'm going to talk about, which attempts to make sure that all girls look standard, in theory, it probably would make your life easier, although we don't have actually data to show that. The data that we have does not actually show that growing up with a big clitoris or growing up even with genitals quite in between causes you psychosocial problems. That's been an assumption. So prenatal dexamethasone is the intervention that has been used since the early 1980s to try to target the mothers at risk for having a girl of this type and prevent them from developing sexually atypical if it's a girl in utero. So dexamethasone is a potent steroid of the glucocorticoid class, which basically means it's a pretty intense steroid. Most of the time that it's used prenatally, it's used for when a baby is going to be born prematurely because it helps to develop the lungs. And in those cases, it's a different kind of treatment. It's given in a bigger dose, and it's given once. And the attempt is to get the baby to develop lungs mature enough in order to survive when it's born. That's given in the late second or early third trimester. This is a different use. This is a use used very early in pregnancy. Dexamethasone use in pregnancy cannot prevent CAH. Again, what it can prevent is the sex atypicality, theoretically. And this intervention delivers 60 to 100 times the normal level of glucocorticoids to the developing fetus. So it's quite a high dose of glucocorticoids for the developing fetus. Although it gets described as low-dose dexamethasone therapy, it's low dose for the woman. But what's reaching the fetus has been estimated by Ben's researchers to be 60 to 100 times the normal levels. The intervention is necessarily started before week 9, because if you don't start it before week 7, you can't affect that genital differentiation, because genital differentiation starts so early. But it's been started, in fact, as early as weeks 2 to 3. So what happens is they find these women who usually have had a child before with CAH, so they know the woman's at risk, or through some other kind of genetic screening, they figured out the parents are carriers, the child, any pregnancy, therefore, is at risk of resulting in a child with CAH. And they figure out before the pregnancy, and then as soon as the woman knows she's pregnant, she starts taking dexamethasone. So typically by week 5 of pregnancy, the woman is on dexamethasone. And she'll stay on it until they figure out if the fetus is in fact the kind they're trying to hit, which is an XX with CAH. Because the way the numbers work, 7 out of 8 won't be, right? Because only 1 out of 4 will have CAH, and only half of those will be females. So in these pregnancies where they're targeting it, only 1 out of 8 of the fetuses started on this intervention will actually be the type they're aiming at. And what they do is they continue the dexamethasone until they figure out, is this an XX fetus with CAH? And if they discover it's not, they stop the therapy. If they think it is, they continue it until birth. So what this means is that 87.5% of the fetuses exposed to this cannot benefit because they were not XX-CAH. So this is, when I came upon this, I was quite shocked because this is quite stunning that you would do an intervention like this that's not aimed at saving a life. It can't prevent a disease. What you're doing is preventing sex atypicality. And almost 90% of the children being exposed to it in the first trimester of pregnancy will never benefit from it and carry all the risks. So this has been actually extremely controversial in the medical system, and I don't have time to go into it, but I ended up asking a group of academics to write to the federal government with me, and we asked the government to look into it because we were highly disturbed that this was going on, and especially because it was going on outside of clinical trials where there was no protection for the women in terms of informed consent. And again, I don't have time to go into it. At the end, I'll give you a reading. You can read more. But this has been heavily marketed to women as being safe for mother and child when, in fact, there's no data that support that claim. It's also been heavily marketed as effective, but there's never been a controlled trial where you've done a placebo versus dexamethasone. So we actually don't even know 30 years later if it even works. The estimates from the people doing it are that it probably works 80 to 85% of the time. But how they come up with that numbers is a non-scientific method where they compare those girls to sisters who had been born who had not been exposed in utero, and they kind of guess at what their level of genital development is and then estimate, oh yes, it improved at X percentage. So it's really problematic what's happened. So it's been aimed at preventing ambiguous genitalia and that urogenital sinus in females, but it's also been pretty clearly, some people have said it's to prevent behavioral masculinization and what gets called in the literature gender issues. And what they mean by gender issues and behavioral masculinization is females who act male typical or are more like males than females, and also that higher rate of lesbians and bisexuality. Now the researchers who I've called on this say, oh no, we never said that, so I'll show you what they in fact have said in their grants and their publications, just a smattering. This is from Maria New to the NIH, a grant application for a follow-up study. The spectrum of behavioral effects of 46XX, this form of CAH, ranges from mild to or marked tomboyish behavior of childhood to increased adolescent adult bisexuality and lesbianism through full male identification with requests for sex reassignment surgery, meaning as adults, and legal gender change. In addition, the genital abnormalities and often multiple corrective surgeries needed to affect social interaction, sex image, romantic and sexual life, and fertility. As a consequence, many of these patients appear to remain childless and single. Preventative prenatal dexamethasone exposure is expected to improve the situation. And another example from her grant applications, which we got through the Freedom of Information Act, the overall objective of this study is to fill the gap of knowledge about the long-term consequences of early prenatal DEX treatment on childhood development on the one hand, and the success of DEX in suppressing behavioral masculinization in the subsample of girls with definitive congenital adrenal hyperplasia on the other. There you have it. We're seeing whether or not we can prevent behavioral masculinization, which is clearly decoded within the grant application as being tomboyism, lesbianism, bisexuality. Your tax dollars at work. News colleague, Heiner Balberg, writing in a paper in 1999, CH women as a group have a lower interest than controls in getting married and performing the traditional child care housewife's role, tisk tisk. As children, they show an unusually low interest in engaging in maternal play with baby dolls, and their interest in caring for infants, the frequency of daydreams or fantasies of pregnancy and motherhood, or the expressed wish of experiencing pregnancy and having children of their own appear to be relatively low in all age groups. So what's weird about this population? They don't like playing with baby dolls. They don't dream about being mommies. So what do? Long-term follow-up studies of the behavioral outcome will show whether prenatal dexamethasone treatment also prevents the effects of prenatal androgens on brain and behavior. Now, we could say, and I think it would be fair to say, that Meyer-Balberg might not be saying we should do this, but he's saying we're going to see if we can do it. But I think in New's case, it's pretty clear that she was interested in saying to the government, we want to see whether or not this is successful in doing prevention. And I'll give you just another quote from one of her talks to a group of parents. This is on a videotape that somebody gave me where she was lecturing to a group of parents who are at risk of having children of this type or have already had children with congenital adrenal hyperplasia. So what she was doing was showing a picture of a baby with ambiguous genitals, and this is what she was saying on the tape. The challenge here is to see what could be done to restore this baby to the normal female appearance, which would be compatible with her parents presenting her as a girl and with eventually becoming somebody's wife, meaning a man's wife, and having normal sexual development and becoming a mother. And she has all the machinery for motherhood, and therefore nothing should stop that if we can repair her surgically and help her psychologically to continue to grow and develop as a girl. And within that tape, she talks about dexamethasone as being something that might prevent the sex atypicality in this population of girls. So this has not been expressly stated in all of the papers published on this as the goal, but you can see from the 1980s on that the researchers kept asking the question, well, while we're preventing the genital ambiguity, could it be the case that we're also going to prevent the gender issues, as they call them, in these children? So what do we know about the outcomes of prenatal dex versus congenital adrenal hyperplasia? Practically nothing. It is shocking that after 30 years of use of this, of a drug absolutely intended to cross the placental barrier, absolutely intended to engineer fetal development in a different direction, it has been studied almost entirely outside of clinical trials or not studied at all. So in the United States, what do we know? Well, as many as 2,000 fetuses appear to have been exposed under this treatment, including the 90% who never even had CAH-XX situation. It's been advertised as safe for mother and child, yet there have been no controlled studies of efficacy. And when they do finally publish the retrospective studies, which was done this past year, it only included 3 to 12% of those exposed. It was a convenience retrospective sample, which means they go back and see who they can find. And then the outcomes indicated a sample bias. So basically, the outcomes indicated that the brains might be better off if you give kids dexamethasone, which is not borne out by what the animal literature would suggest or what the bench research would suggest. And the researchers went through, gave all these reasons for why would we get this effect where the kids, and they didn't come to the most obvious answer as to why you would get this strange effect, which is that the sample was a biased sample. In Sweden, by contrast, they did finally do a prospective long-term trial which showed a severe adverse event rate of 18.6%. Almost 1 out of 5 of the children exposed had a severe medical problem. And that included 3 cases of mental retardation in a sample size of 42, feeding disorders, and this was included in kids who never had CAH, because of course they got swept into this sample. It also included things like hypospadias in one of the boys, which is an indication, the original theory had been that this would not affect the males. It would not feminize, so-called feminize the males, because of the way feedback loops work, that the males would essentially fight against the dexamethasone and it wouldn't have this effect. But the fact that one of the boys had hypospadias actually gave some concern to the researchers that in fact they were, while they were trying to force the girls to be more feminine, they accidentally had dragged some of the boys to that end of the spectrum as well. And actually when they do the cognitive and psychological outcome studies, they've also found in a Swedish study that the boys are, how do they put it, the boys are skewed towards the neutral, which when I told my husband this, he said, does that mean they like beige? And I said, no, it means they like pink. And that's what they're concerned about, is that in fact they've accidentally now, in trying to drag the girls to be more socially acceptable in terms of female type, they've also accidentally taken the boys and dragged them over to the female side of the spectrum. So the Swedes actually shut the entire intervention down in 2010. They're continuing to study the children who were exposed in a long-term study, which is the responsible thing to do. But the Swedish team has actually gotten quite pissy in the medical literature and has started saying things like it is absolutely unacceptable that people are continuing to do this outside of clinical trials. They've gotten extremely pissy, which is interesting because in the medical literature, stuff doesn't usually get that pissy. So that was prenatal dexamethasone for CAH. And just to wrap up, what's wrong with trying to engineer a child's sexual orientation to make him straight or gay? And when I started publishing this work on prenatal dex, people were asking me this question. So I had to sit down and kind of make myself a list. And I'll give you the list of what I think is wrong with this. First of all, messing with embryos and fetuses is frankly a dangerous game. We know this from the history of people messing with fetuses and embryos. And so we know, for example, from the history of DES, which was given to somewhere between 5 and 10 million pregnant women in the United States, that when you start giving pregnant women drugs that you don't really know what they do, you might end up having long-term negative effects that you didn't mean to have. So DES is a different kind of drug. It's not a steroid, but it's a synthetic estrogen, and it was given to women mostly to try to prevent miscarriage. It was advertised under the claim that it would make a normal pregnancy more normal, and that it would lead to healthier, bigger babies. In fact, the early studies of DES, when they actually did a study of it in the 1950s, it actually showed that women had more miscarriages on DES, not fewer. But that didn't slow down the use of DES. The drug companies kept selling DES, it kept taking off. And so it was only in the 1970s, in 1973, when doctors figured out that, in fact, an unusual cancer was showing up in girls whose mother had taken DES when they were pregnant with them, and it was a particular kind of vaginal cancer that's often fatal. And by the way, the only reason they figured this out was because they were doing the epidemiological study. They had this sudden bloom of girls who had this very rare cancer, this cancer that until then had only showed up in old ladies, and even then very, very rarely. And so they were going with the mothers through all these questionnaires, and it was one mother who kept saying to them, I think it's that drug I took during pregnancy. I think it's the DES I took during pregnancy. So the scientists took her tip and actually went and asked the mothers of the daughters who had this cancer, and sure enough, 7 out of 8 of them recalled taking DES. And suddenly it became clear. It took the FDA almost 30 years more to actually pull DES from the marketplace. They just did that recently. So you cannot count on the FDA to take care of these things. But we know from these kinds of histories and from the history of thalidomide and other kinds of drugs that messing with embryos and fetuses is a dangerous game. You might think you know what you're doing, but in fact you can cause all sorts of dangers when you start to try to engineer the fetus in the womb as being one thing or another. Secondly, gay and lesbian people aren't the problem to be cured. The problem to be cured is social discrimination, right? And as I study people with unusual bodies, people like conjoined twins, what strikes me is that over and over again, their experience is the same as folks, for example, who are gay and lesbian, or people who are black, or women. People who are on the oppressed side of the social spectrum do not feel that they are the problem to be fixed. They understand very clearly that they are subject to all sorts of systems where somebody gets more stuff than they do. You know, if I were to say to a couple that the woman was pregnant, and I was to say, well, we're going to do this genetic test, and your baby might come up this or this, and there's about a 50-50 chance, right? If the baby has this particular condition, things are going to be pretty good. But if the baby has this other condition, here's what's going to happen. That child will be much more likely to be sexually assaulted, will earn less on the dollar, will be much less likely to ever be elected to political office. You know where I'm going here? So here's the male, and here is the female type, right? But we don't say, just because it's true that women are still discriminated against socially, economically, politically, that the solution to that is to make us all men. The solution to the problem that gay and lesbian people face is to solve the social broken system, not to try to say that what we're going to do is bring children into the world who won't suffer. I understand very much, because I'm a parent, I understand very much the instinct to try to prevent your child from having any suffering. That's a normal parental instinct, and I think it's a positive parental instinct in many cases, but it's not realistic. Children do not come into the world never to suffer. So the question is, what can we do for the child that does come into the world? And in this particular case, I think we can say the world is changing enough that there really isn't a reason to try to prevent a gay or lesbian child. Attempts to prevent homosexuality are profoundly anti-democratic. What they say is that we're not going to change the social system to deal with the needs of the few. We're going to say we just won't have those few, and we'll just make sure that the many are always taken care of. And what's really cool about the American social system is that the way the founding fathers set up our system was to say all men are created equal. Now, they didn't all believe that, actually, right? And they certainly didn't say all women are created equally with men. But they did set up a really cool system that we've used since to say body type is not a requirement of social rights. And so we're not, I don't think, in a situation where we want to say that you have to be born with a very particular body type in order to be acceptable in our system. I think we can do better than that and not have an anti-democratic system within medicine. Committing to a child means committing to things you would not have chosen given a menu. So I say in an essay I wrote on this for Psychology Today, which is an essay called To Have is to Hold, am I saying that people who won't accept a gay and lesbian child into their life are unfit to be parents? Yeah, I kind of am. And here's why I'm saying that. Because when you commit to having a child, you're committing to a lifetime of uncertainty. You don't know what you're in for. You know, you could have a child that is born socially perfect in every way, but that child may still dive off the short end of the swimming pool and end up breaking their neck. And are you going to then say, oh, that's not the one I signed up for, I'm giving it back? No, you don't get to do that as a parent. So as a parent, one of the things you have to do is to sort of commit to the fact that you're committing to a lifetime of uncertainty. And this seems to me within the realm of the level of uncertainty that parents can reasonably ask to assume. Are there certain situations where we say, well, there are situations where people should be allowed to refuse a pregnancy or end a pregnancy if they're in a situation where there really is a child that they think should not come into the world? I am pro-choice. So, for example, I think if a child is, or a fetus is diagnosed in the womb as having a fatal disease where they're going to suffer for a couple of years and then die, where it's going to be really, really horrible, and the parents want to make the decision this child really can never know the world, can never ever have any kind of decent quality of life, is that a reasonable option? In those circumstances, I think so. But we have to think about the situation where we're talking about gay and lesbian people. We're not talking about a life that has to be a life that is meaningless or full of discrimination. And then finally, I would say, would-be parents have to accept that their children are going to change them. So when we try to get into a situation where we engineer our children to be particular things before they are born, one of the things we're doing is actually engineering our own identities. And what I mean by that is, if, for example, you want to pre-select an embryo to make sure you're going to have a girl child instead of a boy child, or you pre-select an embryo to make sure you're going to have a child of one type versus another type, one of the things that's happening is you're necessarily making a decision about your own identity. And I think inevitably we do that as parents. We're often working out our own identity issues when we're working out our children's issues. So a lot of times when we're figuring out what school our kid is going to go to, or what instrument they're going to play, or what sport they're going to play, or what they're going to be when they grow up, we're working out our own issues. And it's sort of inevitable that we'll do that. But as we do that, I think we have to accept the fact that we're not always going to win that game. And some of the time, a lot of the time, what has to happen is we need to be ready to change in response to what the child needs from us. And trying to do a kind of engineering where you try very, very hard to prevent homosexuality or something akin to that strikes me as something where you're saying, I don't want my kid changing who I am, when in fact you have to accept as a parent that a child will change who you are. So that's just where I'm going to end and just say thank you to the folks who have supported it. If you want to read more, my Psychology Today blog has this essay, To Have is to Hold, which summarizes the arguments at the end there. And then the paper where we track out what happened with prenatal dexamethasone is available for free at the Journal of Bioethical Inquiry. You can find it online pretty much just by Googling my name, or go to fetaldex.org, which is a website I set up to triage all this stuff. I paid $3,000 to make that paper free, so please download it and read it. That's the way academic publishing works.
And I should also point out, you can also get links to all these things if you go to alicedreger.com. Right? So, questions? Yeah.
The mechanism for prenatal dex, do we understand how it was supposed to work? Do we understand that, or was it all purely hypothetical?
No, I mean, the scientists who work on it and the researchers who work on it have these big fancy diagrams. So basically, the way I would summarize it as somebody who's not an endocrinologist is the idea that it's supposed to fix the cortisol loop so that you kind of dampen down this feedback loop where you've got the ever-increasing masculinizing hormones. So theoretically, it should work. And actually, when the French researchers who started doing it began doing it, they tried out a couple different steroids. And they picked this one because they had one case where it seemed like maybe it worked. And that's why they went with dexamethasone. I was actually shocked when I found the original paper because I thought, well, where's the original paper that, put forth this idea? it was a case where they had 6 different cases and they tried a bunch of different things, and they had one where they used dexamethasone and it seemed like it worked, so everybody said, oh, it looked like that worked, let's do it. And they just started doing it. No controlled trial, no efficacy study, it just took off. And the reason for that is because of the kind of phobia that occurs around that population.
Well, but clinical pharmacology often follows that trajectory. I mean, this wouldn't have been the first time.
Yeah, one of my friends said to me a couple of days ago, you know, I never realized how bad medical science is until I started following your Dex work. It's kind of scary.
So what can someone like me that's just a person, obviously nothing, I'm not anyone that can do more studies or anything, what can I do to make sure that stuff like the Dex doesn't ever happen again? And now I just found out that there's other studies that have been doing similar stuff like that. Like how do we just prevent this since we don't have any control in the scientific community?
That's a good question, and when the height of this was going on, I would have said you could write to the FDA and they might actually listen to you, but right now they're not listening to any of us anymore because they decided we made too much noise and it was uncomfortable. But one of the things you can do is talk with people about it, but the other thing you can do is actually question your own physician. So I presume you're not at risk for having a child with CAH and you're not planning to take dexamethasone, but what you can do is when you encounter your own physician or whoever your healthcare professional is, whether that's a nurse provider or a physician, is to every time they're about to give you a drug, stop them and say, what's the evidence that this is necessary? In other words, what's the evidence that what I have is problematic enough that I need a drug? What's the evidence that it will work? What's the efficacy? And what's the evidence for safety? And can we go over that together? And if you do that, you'll be helping push from the ground up in terms of forcing people to follow what we call evidence-based medicine. So one of the things you can do is to help retrain the medical establishment by pushing them to think in ways that are much more careful about not just safety and efficacy, but necessity. So my partner trains residents, and one of the things he likes to say to them is, don't just do something, stand there. And what he means by that is, before you rush in and give something, you really need to ask yourself the question, what's the evidence that doing something is actually necessary? Is it possible that this is going to resolve more likely if I do nothing and introduce no harm than if I rush in and do something? And that's the first question within medicine, is what's necessity, and then ask the questions about safety and efficacy. It's really interesting. You know, when I, for example, go to get a vaccine, one of the things I ask is, where's the evidence for the efficacy and safety? And they always look at me like, no, it's a vaccine, we don't have to ask this question. No, I'm not an anti-vaccine person, I'm not phobic about vaccines, but I just want to know the data. Because there are rare side effects from vaccines, some vaccines more than others. And just asking that question forces them to go and get that paper and start reading with me. And inevitably they say, that's interesting, there's this. So start having that conversation. Encourage your friends and your family members to also have that conversation. If you have a child or if you're pregnant, be especially urgent about asking those questions. Because the way pregnancy is managed in this country in general is insane. It's not evidence-based.
And in my experience, when you ask physicians about, what's known, often they don't know because they have to see so many people, and they have to learn so much squeezed into that training, and new drugs come on the market all the time. It's hard to keep it, but to the extent that the clients are asking them about it, as you say, it will.
And you can also pick a physician based on whether or not they actually do look stuff up. You can actually ask them lots of questions at the beginning about whether or not they practice evidence-based medicine, what kinds of databases do they use, and start pressing them on these questions about how they're looking stuff up. I go to a physician at MSU who's actually extremely evidence-based, and he's constantly handing me studies and data, and it's really cool. When the question comes up, is it time for me to get a mammogram, we actually sit down at his computer and look at the recommendations from the Association of Healthcare Quality Research, and we go over the demographics for my age, my risk factors, and we go over that question of what's the data in terms of whether or not it's worth it. I saw two hands over on this side.
Yeah, but I'm waiting to see if there's one over on this side first, since I'm at this side.
No, Mark, I made sure to ask them. I thought you needed more exercise.
Okay, good.
I ask people to be sure to make you keep.
Yeah, I will say, a couple of times I've had a physician tell me, well, there's this treatment that people sometimes do, although in placebo-controlled studies it doesn't work.
Right.
But you might try it. And Why would I do that again?
You should say, give me the placebo. I like sugar pills.
The placebo has fewer side effects.
Exactly, most of the time.
So earlier you mentioned something about cultures with no reported masturbation and no reported homosexuality. Could you say something more about that?
Yeah, so this is the work of Bonnie and Barry Hewlett, who are at Washington State University in Vancouver, and they've studied two populations, the Nagandu and the Aka in the Central African Republic. And they actually had been studying those populations a long time before they started asking questions about sexual practice. And so that's a good way to do it, because it's important to have a good rapport with the people you're studying before you get into sex, because sex is a delicate issue in every culture. It turns out one human universal is that people joke about sex, they like to do it, they like to have sex in private, and they are awkward about talking about it some of the time. But what happened was the Hewletts were sitting around a campfire with some of their informants one day, and the men were talking about having had sex multiple times in a night, and they thought they were just bragging, but then they started asking the women, and the women were like, yeah, that's how we do it, you know, that's frequently how we do it. So they just said, wow, we should really study their sexual practices, because that seems unusual compared to our culture. So they started asking a lot of questions, and they actually tried to ask questions about homosexuality and masturbation. There were no words for it, and just describing it was actually linguistically really difficult, even though they speak the language. And as they tried to explain it, the folks they were explaining it to were just kind of like, oh, no, that's not something we do. And it's not that they're phobic about it, so there's no cultural prohibition, which is interesting, because you might expect, oh, it's because it's forbidden in this culture, but it's not. It's not that they have a prohibition against it. It just appears that they're dedicating their sexual energies so intensely towards reproduction that they see that as the way that sex is done. It's a really surprising result, but it's not unheard of in other cultures as well. So like I said, it'll probably be out, my editor tells me it'll be in the Atlantic tomorrow, so if you look at my website, I have a new section, and I'll pop it up, or it'll be up tomorrow, I think. It's a really, really interesting study. That doesn't mean that there are no people there with homosexual desires. It just means that there's no cultural system for homosexuality. The masturbation thing is harder to explain. There are a lot of species besides humans that seem to engage quite regularly in masturbation, so it's rather surprising that there are cultural systems where it doesn't seem to occur. And believe me, I asked them over and over, you're sure? You're sure? You asked them about this? You asked it? And they said, yeah, we sure did. And they just kept looking at us like we were weird.
Other questions? That looks like I have one over here. No, it's good.
No.
So, Dr. Dreger,
this is the guy from my conflict of interest disclosure earlier.
The anti-democratic portion of selecting against something is going to come head-on against the democratic principle of choice, especially as people get more and more genetic information, and if there are actual functional registries where scientists can control for information. So how do you see democratic institutions working this out?
Yeah, that's a good question. I would say that I would not legislate against women choosing abortion, for example, or choosing intervention, because I think that's a bad way to legislate pregnancy. But I would say that culturally, we could change the way culturally we think about something, and that we should try to do it that way. So it seems to me that the solution to dealing with something like civil rights issues and racial issues is to try to legislate where appropriate, where it does not interfere with people's basic rights, but at the same time try to do cultural change. So I would attempt to do that. So you and I remain pro-choice.
So, I so appreciate you having a question now and not after that lady over there.
Hi, I have a question. I'm in a genetics class right now for animal science, and we talk a lot about what we think should happen now that we're able to see the genome and be able to look at SNPs and start predicting things. What's your opinion about that possibly in the future being implemented in humans, where they could just swab their mouth and start looking at their genetics, possibly even at their future progeny's genetics? Do you think that's a good thing, or what do you think could be the results of that?
I actually don't think more information is always better in an individual case. I think scientifically more information is always better, but in a personal situation, I think that we're assuming everybody will be very anxious to in fact find out everything about themselves and everything about their children. And I think interestingly, I actually think we may be less interested in that, and actually I think we should be less interested in that if we're going to subscribe to a simple genetic determinism. So if people are going to continue to think that when you look at a genome that somehow tells you everything you need to know, then they should not be looking for themselves or their children, because that's a really naive way of thinking. You know, the genome, looking at the genome doesn't tell you everything about people. So I'll give you an example, right? If you were to look at my genome, which I've never done, I don't even know if I'm XX, by the way. Most of you probably don't even know what your sex chromosomes are, because we don't look, and we don't need to look. It's not important to who we are. And for the same reason, I would say we should, in general, not bother looking at our children's unless we think that there's a disease that actually really, truly can be treated and needs treating, because it doesn't tell us who we are. But if you were to look at my genome, you would look and you would say, this being is incapable of flight, right? There's nothing in this genome to allow this person. Well, I flew to San Diego a couple weeks ago. I flew to New York a few weeks before that, and I flew to Halifax a few weeks before that, right? Looking at an individual genome does not tell you what a human is capable of, because human beings actually have a social system that allows them to be capable of far more than our individual genomes ever allow us to be capable of. And a cultural system can change the way a genetic trait is expressed. So what that says to me is that if we're going to look at our genomes and have a simplistic genetic determinism, we might as well not do it. If we're going to look and think about probabilities and think about possibilities, then maybe we should look. But even then, the tendency of the human is to say, well, if there's a 90% chance of that, that means it's going to happen, right? When you end up feeling that way, I ask you to think back to November 2012 when Nate Silver swore to us that there was an 85% chance that Obama would win, but we were all still worried. And remember, the 15% is still a possibility. Romney could have won. And so it is possible, right, when you look at a child's genetic makeup, to say that they have a 90% odds of something doesn't mean 100%. And it doesn't tell us, in fact, how that child is going to grow in terms of the real cultural situation. So that would be my tendency, is to not be overly persuaded by genetics as being the thing that tells us who we are. I got to meet, let me just tell a quick story, Mark. I got to meet by telephone a man a few years ago who was 19 years old, had an extreme form of congenital adrenal hyperplasia. He was a genetic female, but didn't know it until he was 19 years old, and he was having a medical crisis, which was an adrenal crisis. And he went to a hospital, and they figured out that actually he had ovaries inside and a uterus inside, and he was 46XX. He had developed as a fairly typical male because he had a very high level of androgens. And the doctors were trying to convince him to get a sex change, which I thought was absolutely ridiculous. I asked him, do you think of yourself as a man? He said, yes, I've always been a man. And I was like, why would you get a sex change just because you have ovaries? And what I said to him was, I don't let my ovaries tell me what to do. I don't think you should let your ovaries tell you what to do. And I feel the same way about your genome. I don't let my genome tell me who I am or what I do, and I don't think you should let yours tell you who you are or what you do. I think it can inform your life, but it should not be anything like a map to how you live.
And as you say, the other thing that's risky about using your genome is that another proof that we're so horrible at probabilities is the lottery, right? So the mega lottery. I mean, that's proof that humans are terrible at really, understanding probability.
So you didn't buy a ticket, Mark?
So what do you say to people who, through therapy, religious conversion, say, I have been changed. I rode a bicycle or something. I mean, what do you say to them? Are they living a lie?
No. So there are three components to sexuality. One is desire, one is behavior, and one is identity. And in such circumstances, I would say that you've probably managed to change your behavior and managed certainly to change your identity. Now, whether or not you've managed to change your desire, the scientific evidence would suggest you haven't. What you've done is suppress a desire. Can we suppress sexual desires? Absolutely. And that's why I don't think that basing gay and lesbian rights on the argument that they're born that way makes any sense to me. Because in some ways, we could say, well, you have to be born that way in order to have that desire. And we know that, in fact, people can be born with all sorts of sexualities that they can repress, right? There are plenty of religious people who are sexual, who have sexual feelings, but have, through religious devotion, decided not to have any sexual acts. Some people are capable of this, but that doesn't mean that the right solution to it is to ask people to do that in a circumstance where what we're talking about is a kind of sexuality that involves consenting adults. Now, pedophilia is really interesting because it does appear to be a sexual orientation, And it appears to be something, again, you can't change. So if a man is pedophilic, and it's statistically almost always men, if a man is pedophilic, can he go through a kind of therapy that will help? The answer is you can squash down the sexual interest level, for example, through chemical castration, but you can't actually change the direction of that orientation. If anybody should want to change their orientation, it would be pedophiles, because they're in a situation where their desires cannot be morally or legally satisfied. Those people probably have the highest incentive on the planet of people who would change orientation, and they have not been able to do so. All we can do is dampen down the sexual desire in those cases.
And help them control the situation to avoid.
Yes, put them in
Circumstances.
situations where they don't have access.
Another question? All right, well, I told you you'd be interested. Thank you.
Thank you.